Welcome back, everyone. I hope you enjoyed your coffee break. My name is Melissa Nolan. I'm the GIS Core Director, and I have the honor and privilege of introducing our next speaker today. Dr. Windsor Westbrook Sherrill is an incredible woman, very impressive. She holds 3 different titles. She's the Provost Distinguished Professor of Public Health Sciences and the Associate Vice President for Health Research at Clemson University. She's also the Chief Science Officer at Prisma Health Upstate. And today she's going to talk with us about how she's been able to leverage some of these partnerships over the years. Some really incredible accolades that she's accomplished over the years are her research initiatives have garnered more than $19 million in extramural funding. She's the 2012 recipient of the Award of Excellence from Clemson University. She's also served as the faculty representative for the Board of Trustees at Clemson. She's an SC Liberty Fellow. She's on the board for the South Carolina Institute of Medicine and Public Health. And if that's not enough, she's just a lovely colleague and a great person to collaborate with. So without further ado, we will introduce our next keynote speaker, Dr. Sherrill.
Greetings from Clemson, South Carolina. And I'm pleased to be part of the National Big Data Health Science Conference this afternoon. We're pre-recording our sessions, but I will be with you online together for discussion as we're all enjoying the virtual environment for our conference today. And hopefully in the soon future, the near future, we'll all be together again for in-person conferences. I believe that Dr. Melissa Nolan provided my introduction today. I want to say thank you so much. As many of you know, Dr. Nolan is a health researcher to watch in South Carolina. She's doing incredible work in infectious disease and other areas, and we are also pleased by the impact of her research for our state and the nation. So thank you, Dr. Nolan. Glad to be here today. As Dr. Nolan said, I'm Windsor Sherrill. I'm based at Clemson University, Professor in Public Health Sciences, and also Associate VP for Health Research. And I also serve as Chief Science Officer of Prisma Health Upstate. All that is to say that I probably know less about data analytics and artificial intelligence and data science than most of you who are in this conference. But I can say to you that I'm a disciple of the potential and the promise of data analytics for health outcomes, health research, and health status in our state and our country and around the globe. I believe that data, specifically health data, is the critical tool for us in our future. It's the data moonshot. If we can get this right, we can improve population health, health outcomes, and health equity. This is critical and a reason for us all being here today for the Big Data Health Science Conference. So let's talk about what it is when we say health data, health big data. And why do we care? What does it mean to us? Big data can be defined through many lenses. As the name suggests, big data represents large amounts of data that's unmanageable using traditional software or internet-based platforms. Big data surpasses traditionally used amounts of storage, processing, and analytical power. Many definitions exist, but Doug Laney has the most popular, and he observed that big data is growing in 3 different dimensions: volume, velocity, and variety. And a 4th can be added, veracity. So to us, to scientists, to practitioners, to clinicians, health data, health big data means many different things. But what it does mean to all of us is what it can do as far as addressing barriers to accessibility in healthcare. So let's think about the areas, the lenses through which we define health data. People typically think of health data as electronic health record data, EHR data. And consider in many senses, this is really a relatively recent phenomenon. We did not have widespread electronic health records until about 30 or 40 years ago. And even then, we've only had in the last about 20 years through federal regulation the push for integratable electronic health records. And now, as you know, we have just a couple of primary vendors of electronic health record, such as Epic. So our electronic health record is a reflection of health services consumption. That is, what is somebody getting in private health services? Those medical claims that are created by the electronic health record serve for us as a proxy to predict health status. That is, if I receive orthopedic services, I probably have an orthopedic problem as a diagnosis. But literally in many cases, medical claims data is really a proxy for health status. EHR data is a reflection of health services consumption. It also might include things like payer status, and it's medical data that reflects individual health status. Rolled all together, individual health status data becomes population health status data. The EHR, medical claims, medical consumptions information, is what people may think of when they think of health data. But there's a lot of other sources of information that determines health status and health outcomes. Social determinants of health data, education backgrounds, demographic information, economic status, where I live, accessibility to healthcare organizations. All of these things are also sources of data that tell us something about the health of a population. And our challenge is putting all those pieces of data together to make sense to us in a way that we can know more about population health needs and population health status. So think about all these different modalities of data. And think about the challenge of integrating all these together. We've discussed EHR data. But remember, that's not necessarily a database. An electronic health record may be Word files, maybe some data files. Oftentimes we have to convert electronic health record data into a searchable database. That in itself is a challenge. We said medical claims data, third-party payers. What payers are paying on our behalf of our healthcare services? And again, medical claims data is often a proxy of healthcare consumption, but also healthcare status. Pharmaceutical data. Remember, your EHR data is based in your third-party, in your provider system. Your pharmaceutical consumption data is in another resource, pharmacies, Walgreens, CVS, independent pharmacies. We've got genetic data, biologic data. Who would have thought, even 15 years ago, that people would be willing to put their genetic data into a database, 23andMe and others. Consider that as a source of big data, if you will. We have population health outcomes data from sources like CDC, from our public health entities, from research entities. GIS system data, looking at where patients are, where health resources are. Epidemiological data on individuals and populations, human behavior data, consumption pattern data, smoking status data, seatbelt status data, what individuals have been in the justice system information. Again, all these things, all these pieces of data can provide some element that adds to that picture. And our challenge is, consider all these things are in disparate locations. They have disparate owners managing them. Who on earth could even begin to integrate all these things? Then you've got administrative data, you've got research data driven by all the many different research efforts, social media data. At Clemson, we have a social media listening center. We can actually track conversations around health problems, around diseases, conversations among disease entity groups. Consider, if you will, we don't lack possible sources of health-related data. It's everywhere, it's ubiquitous. But how can we integrate all these pieces in a way that makes sense, in a way that can be studied, in a way that can be shared? That's our challenge. So why do we need to do this? Why do we need to integrate and share and understand all this information? We are swimming in health data. Why does it matter? We talk about population health management. We talk about the challenges of health equity and improving health outcomes. We could spend all day talking about the fact that we spend so much on healthcare in this country, and yet our outcomes are no better than other developed countries who spend a lot less. How can we know better how to spend our healthcare dollars in the way that provides the best outcomes popular? The challenge of population health management. Only improved data analytics, only improved data management can provide us the opportunity to improve population health, and that's our challenge. The entire health universe is focused on this problem. Here's evidence. In 2021, the National Academies of Medicine, as you all know, the key non-government entity influencing health policy since the 1800s, issued a special publication on sharing health data, sponsored by PCORI. This report, Sharing Health Data, the Why, the Will, and the Way Forward, outlined the case for sharing and integrating health information, and it featured case studies of organizations making progress in this space. This is literally a call to arms in health data science. And as you all know, evidenced by our conference here today, we're gathering steam around the nation around this challenge. So again, why do we care? We want to address shortcomings that affect healthcare and health equity. We want to build a foundation of trust that will enable collaborative data sharing activities with shared values and innovation. Particularly in our country, misuse of data has spawned a legacy of mistrust. We have to overcome that legacy in convincing stakeholders, including patients, including communities, particularly underserved communities, to be willing to share their health information. We need to build that trust that we'll manage it appropriately and manage it carefully. We need to think about motivating new thinking and action from both providers and researchers. If you think about, there's a cultural divide between the researcher approach, if you will, to health data science and the provider approach. I have an opportunity in my job to work at the nexus of a healthcare system and a university trying to build healthcare research. And oftentimes we find that there truly is a cultural divide between those two groups. I have a researcher say to me, well, can I just get the EHR data? And we often as researchers think that's a ready-made data set for us to study. Our providers, our healthcare systems know that's not necessarily the case. And there can be frustration there in either oversimplifying it or being too protective of that data. Again, if we do this correctly, it can foster better healthcare delivery and better healthcare outcomes. We hear the language again and again of a learning healthcare system. And sharing data has to be the bedrock of learning healthcare systems. That is, data-informed innovation, data-informed change, and data-informed transformation. As we are doing a better and better job increasingly integrating, amalgamating data and information, we're going to see the value to transform healthcare increase very significantly. Think about this, the progress we've made in this space. 15 years ago, who would have thought, even have conceived of the idea of patients having access to their own medical records? Today, legislation obligates healthcare systems to provide patient access to records, and patients are more and more comfortable with that. It's now the norm, not the exception. 10 years ago, it would have been inconceivable for patients to provide their genetic data to a repository, to be comfortable doing so. More and more, this is becoming part of our healthcare system and the environment, and it's up to us to build this and build that confidence in individuals' willingness to share data to further the research enterprise. So why is this so hard? We talk about it all the time. We say health data is the tool for population health, data analytics. Why can't we just do it? Why can't we just share the data across the system? Here's a way of thinking about this is probably the hardest thing we've ever dealt with in the past 20 years in health research and health systems. I would say it again is the moonshot. It is almost, if we can figure this out, it's almost like typing the genome or some other comparable challenge. Think about the healthcare system like this. We looked at all those different sources of data. They're myriad. How do we integrate across? The healthcare system is one of the most complex sectors as an industry in our country. There's no other industry quite like it. If you think about it, we have patients and consumers, we have providers in the context of healthcare organizations as well as individual providers. We also have third-party payers, again, insurance companies that are very involved in the healthcare transaction, but yet aren't the buyer or the seller. In the middle of all that, we have government intervention, which is so significant in healthcare, government as a third-party payer, as well as government as a regulator of the healthcare system. And so if you look at these areas, you look at the funds flow passing across the production and delivery side, the financing side, the reimbursement side, but just consider, and even just saying third-party payer, consider how many different third-party payers there are in our healthcare system. So you're starting with a very complex industry. Now I would submit to you, here is your model of the medical care system. Very, very complex because of that third-party payer entity, because government as third party as well as provider, because of so many different types of providers. Remember we said pharmaceutical companies, long-term care companies, dental services, not just hospitals, many different healthcare sectors. But now think about where the data is and think even more complex. All those sources of data we talked about, claims data, research data, social determinant data, is in different locations and is controlled by different entities within the system. So if we think about the challenge of sharing data across all these entities, this is why it's so challenging. Healthcare providers, healthcare systems control the EHR data, the service delivery, the consumption data. The third-party payers control the reimbursement data, the claims data. Individual patients and consumers control their own data, their own consumption data, patient-sourced information, genetic information. And then across the system, we have research data, administrative data, financing information. So where the information is located is incredibly complex in the healthcare system. The number of stakeholders that are working here is incredibly complex. So this is why we have a situation where it's very, very challenging. And those of you who are at this conference, I doff my hat to you because you're working on this challenge and trying to untangle this Gordian knot to try to, again, leverage data to its best use to improve health. So, how are we going to deal with all the barriers to this? We've talked about the cultural and access barrier. Researchers that maybe have the research tools, the AI tools, may not be as familiar with clinical records and healthcare data. There are an incredible number of operational barriers. We've got many different potential tools, but no one entity can have unfettered access to all the records and all the databases, okay? They're all managed on different platforms. Again, medical records may not be an easily searchable database. They have to be converted in many cases. In healthcare, you may have a very significant lag time from when data are collected to when they're available. Consider, if you will, how long it takes to make a data consumption or a delivery of data services translate to a claim, translate to a reimbursement, And all those are steps in the data chain. Again, you've got a number of different owners and sources of the data. There are very impressive financial barriers to achieving this. You've got significant cost associated with data procurement. And consider, if we have thousands of different owners of the data, which owner should bear the cost here? We've often said this is why we'll take a national initiative with government funding support to really make this work. It's also critical to realize that health organizations or other organizations that own a lot of this data definitely have a perception of loss of competitive advantage if data is shared with competitors in their market, with third-party payers, and it is true. The healthcare organization knowing the most about their patient status is a valuable competitive tool for them. A tool and information they don't necessarily want to openly share with a third-party payer, with their competitors. And also, they're not allowed legislatively to share information about individual patient status for good reason. So obviously we also have ethical barriers here. Appropriately so, we have significant privacy concerns, privacy regulation regarding sharing of data and health data and personal data. Disagreements about who owns the data. Does the patient own the medical record? Does the health system own the medical record? And the misaligned incentives. Those might be financial incentives. Those might be ownership of the data incentives. But all these things are significant barriers to us achieving true data integration. And again, it's important that you realize this is information. Population health data is made up of individual health data, and that is private information. And it's appropriate that we're concerned about privacy and security concerns, that we're constantly focused on that. National Academies of Medicine also convened a stakeholder group in 2020, and they wanted to look at barriers to data sharing that groups experienced or perceived. Lack of trust was a common theme among all three stakeholder groups here: healthcare executives, research leaders, and patient leaders. Researchers have mistrust in the intentions of third-party payer users. Health systems worry that patients will misinterpret data, and they're reluctant to share data for fear of losing competitive advantage. So if you'll notice, again, National Academies of Medicine have been very, very focused on some of these challenges, and look at the way they looked at the different types of mistrust, if you will. Again, among healthcare organizations, there's concern about the financial cost of sharing data. Among patients, lack of understanding the value of patient-generated data, or lack of trust in researchers or healthcare organizations in protecting my data. It's good to look at this analysis of why we don't necessarily trust these three sets of stakeholders. All three are so critical to success in this space, and why there's a lack of trust among all. So how do we solve some of these barriers to data integration? How do we begin to make a difference? It's critical that we developed universal processes for health data sharing. Many organizations are building universal data use agreements. We're seeing great progress there. How do we ensure that transparency around health systems technology partnerships around data? How do we explain and articulate the value proposition to owners both of the data and to patients? Again, to incentivize willingness to share information and share the data. Not just from patients to share their own information, but also large healthcare systems who own much of the data. How do we build a shared infrastructure for clinical data exchange to support population health? And consider you're trying to build that infrastructure across competitors, across healthcare markets. This is a significant challenge because understand healthcare is a competitive business. Again, developing explicit and transparent processes for governance and data oversight, and promoting and building trust among stakeholders. How do we build that trust in a way that will ensure public benefit while also retaining the commercial value of the data for the owners? It is not fair for us just to expect the entities that own the information just to share it openly when that is their competitive advantage. So how do we build an environment to retain that commercial advantage while also building data as a public benefit? So do we see any signs of progress? We have spelled out this is very challenging. We've spelled out this is very important for our healthcare system. Who's doing it well? Who's investing? We can definitely say in the investment stakes, this is not a cheap endeavor. It's not a cheap endeavor for a health system, for an academic medical center, for a university, or for the health sector at large. But we do see some windows of hope. The names we'll talk about: Johns Hopkins, Cleveland Clinic. Those are names you often hear about when you think about strong integrated delivery systems and progressive health organizations. Johns Hopkins has created a big data platform called InHealth to look at advanced precision medicine. They funnel data from many different resources, including the EHR, into a cloud-based platform to help scientists and clinicians connect treatment and outcomes with also genetic and phenotypic data. Cleveland Clinic, one of the largest and earliest integrated delivery systems in the country, is actually putting in $500 million in a collaborative initiative. Now note, if you know that Cleveland Clinic has always been ahead of the game in population health and managed health care, and they're putting this kind of investment in this, it indicates to us that this is the way of the future: integrated health and better use of health data. They've built the Global Center for Pathology Research and Human Health, putting together personalized medicine, genomics, virology, drug discovery, diagnostic development, and integration with big data with patient care. Brown University, similar. This is a market integration. Academic institution, Brown University, using big data as a major enabler, is integrating with New England healthcare system and the lifespan hospitals. Thinking about, in some corners of our country, we are seeing competitors get together and try to build this resource, okay, to benefit public health. So those are some examples to follow. We always think about the Mayo Clinic as being progressive. In 2019, Mayo and Google entered a 10-year partnership to design a framework for ethical secondary use of clinical data. Now consider, it probably made the Mayo Clinic take a very hard swallow to partner with Google. But think about it, who's better at data mining? Who was most progressive? Who built this? So there's two components: the Mayo Clinic Cloud, housing patient records, and the Mayo Clinic platform. And the platform is a location where Mayo can share a subset of de-identified clinical data so that researchers can link to it, maybe supplement it with their own data and use advanced data analytics, including AI, to do strong health research. This is the kind of question we often get from our researchers: where do I find the health data? And typically, unless we're able to de-identify it and have a shared infrastructure, we really can't share it very well. So in this case, the data doesn't leave the home system, doesn't leave Mayo, but it's able to be shared in a way that advances knowledge while also maintaining privacy and security concerns. I can give you a litany of different examples, different signs of progress, what we call data-enabled health interventions, situations where actual typical diagnoses, typical health delivery for a certain disease is being informed and improved by data or AI. You guys could probably provide that same list. We've got some great examples. Again, great signs of progress. Just a few. Duke University developed an artificial intelligence system to detect signs and abnormalities related to sepsis called Sepsis Watch. Now remember, think about how important this is to third-party payers, that we don't have sepsis infections within patient hospitals. So the reimbursement system, the payer system, is driving us to use AI and data in better ways to actually achieve that bundle compliance. And indeed, at Duke University, they saw increased significant bundle compliance in the area of sepsis. Diabetes interventions. Kansas Health System, Rensselaer Polytech, again, harnessing data and predictive analytics determine which interventions, in this case, personalized interventions for diabetes, had the best impact on individual patients. In this case, at Kansas City, they use it for pediatric patients to improve outcomes and also to address social determinants of health. Rensselaer, same thing, building those algorithms to control glucose monitors and insulin pumps, enhancing the lives of people with diabetes. More great examples of artificial intelligence applications. Johns Hopkins University is studying use of whole heart computational models using AI. Tulane, over 9,000 subjects looking at colorectal cancer. Machine learning to improve our detection and diagnosis of cancer. Mayo Clinic, again, always at the vanguard, looking at CAT scans using AI machine learning to look at patients with stroke. Preventing heart problems, applying AI to ECGs, looking at how to predict using a database of 7 million ECGs to mine that data to more accurately predict heart failure non-invasively and inexpensively. Think about the progress we're making in healthcare systems and healthcare challenges through AI and data. Such a significant challenge for us is Alzheimer's care in this country. It will just increase. If we can utilize AI, as they are at UPenn School of Nursing, as a point of care medical decision support tool, can make all the difference to improve in-home care for older adults with Alzheimer's disease. So we can talk a lot about great examples of things happening nationally at some of our stellar healthcare systems. And it's so good that we're seeing those signs of progress, again, with individual disease interventions, individual disease treatments, and also large system-based data integration efforts and investments. But let's think about South Carolina for a minute. And just a couple of examples. As I said, I get a chance to work with the Prisma Health Sciences Center. That's Clemson, USC, Furman, and Prisma working together to build health research. We've developed a lot of tools to deal with the challenge of data sharing. Again, we'll often have health researchers say, I'd like to have more health data. And I will share with you all, we have not solved all the problems in this space. It's still a challenge for us. We developed a data support core that connects math stats students with researchers and clinicians who want to use health data. We built shared data use agreements to facilitate data sharing. We developed models of embedded scholarship where we pull faculty from the university setting to the healthcare setting so they can learn more about data science in this case. Student integration, embedded postdoctoral researchers, embedded faculty on pseudo sabbaticals, again, to build that culture of data sharing in ways that make a difference. Look at our state at large. At Clemson, MUSC, and USC, all three of our research-intensive universities in South Carolina are building AI and data sciences programs. We've got growth at all three universities. Now, the challenge is, if all the universities, both the state and also the nation, are trying to recruit good data scientists and build this, it's going to be a challenge to recruit folks, and we need more data scientists for sure. But the point would be, We've all recognized this as a very fertile area for research, but not just for research, also to improve healthcare systems. Clemson and MUSC have a joint program in biomedical data and informatics. They recently received an exciting T15 training grant to provide data training for individuals, particularly to impact health equity. And again, we have the CTSA in South Carolina. It's MUSC led, but Clemson and U of SC are both partners, and increasingly it's focused on data sharing and health data as a resource for health research. One more thing to think about when it comes to data integration, a success story, if you will. Think about how South Carolina and the nation has responded to the COVID crisis by leveraging data resources. In the category of never letting a crisis go to waste, South Carolina and all states during the COVID crisis had to respond very, very quickly to integrate many different types of data to know how to respond to COVID, how to communicate with various stakeholders, how to use data to plan intervention and response. If you think about it, the number of data resources, the number of data sets, the number of locations from which data had to come was very overwhelming in South Carolina and in every state. Think in general, for example, a question that might be asked by a policymaker. Where should we send vaccines first? How many Medicaid patients in nursing homes are vaccinated? Just simple questions like that we heard asked every day. To answer those questions, somebody had to behind the scenes integrate all sorts of data and information. I recently had a chance to hear a wonderful presentation from the public health departments from South Carolina and North Carolina. And our own Linda Bell, who you've heard from today, was one of the great presenters. That presentation made me realize that how we did handle COVID just provides us a window of the potential of working together to integrate data to respond to a public health crisis. And it shows us the promise. Again, many states were more agile than others in their ability to leverage data to inform policy and operations. But we had to look at how we could develop those tools and what those tools we used during COVID have for us as far as promise for responding to other public health crises. The sources of information, we had data as far as COVID incidents. We had data as far as what was happening in different regions, diagnostic information being reported from laboratories, numerous different laboratories, and predictive information. How do we integrate all of those pieces of information? Just think about the things that we were dealing with. Epidemiological data, how many cases did we have? And that case data coming from schools, from work sites, from long-term care, from prisons, not just from laboratories. Individual risk factors, demographics, outcomes for different populations in every region, and to think about the resource data. It seems like a long time ago, but recall the beginning of the COVID crisis, what a concern we had about PPE. Where were the shortage areas? Where should we put our limited resources? Hospital capacity, ventilator capacity, ICU capacity. All those things are pieces of data that to make decisions operationally, we had to know that information. Vaccine access, vaccine acceptability, vaccine management, testing supplies, even information as far as contact tracing. It's amazing looking back at how quickly state health departments, healthcare systems, laboratory systems were able to work together quickly and put together these many, many disparate data resources to have better information to predict and inform our response. Look at some of these dashboards. Clemson dashboard, the WHO dashboard, the DHAC dashboard, and just consider the information that's behind all these dashboards. People every day wanted to know what was happening. How many COVID cases were there? How severe is COVID? What areas are the hardest hit? To provide those dashboards A lot of data has to be integrated, processed, and analyzed. And remember, in many cases, this was information we had not previously integrated before the COVID crisis. I am very proud to share the Clemson tracking. As many of you all know, at Clemson we had our own testing centers, just as many other universities did. But again, another example of a very rapidly integrated, rapidly operationalized response to COVID that used data and information. So think about all the decisions during COVID that data had to be used to inform. How would we distribute limited supplies of PPE, limited supplies of vaccine? What kind of guidance do we want to give to the public, schools, businesses, and communities to give better disease control? What kind of population health data will we have to inform health services and access to care, to determine what were the best health services we need to invest in and provide? Again, all that information to communicate with all the different stakeholders and all the different audiences, both to do advocacy, intervention, and to best use our limited resources during a time when response was critical and our rapidness of response was very, very critical. All that is based on a foundation of always the question, particularly in COVID, of who do we go to for data? Who do we trust? How do we trust this information? It's another example of how critical that transparency and trust is when handling health data and using data to inform decisions around public health or private health. So we learned a lot of lessons through COVID. I believe it's a great example of how we can work together very, very quickly in using data and leveraging data and organizing data. Hopefully, those lessons we learned through COVID, we will now apply to other public health and population health opportunities and challenges. Very unique, again, think back that model of the healthcare system. The U.S. health system has public and private payers, third-party payers, public and private providers, pharmaceutical companies, long-term care, many different sectors. Just like we saw in COVID, information had to come from all those different sectors as a good illustration of how that occurs and the complexity of how that occurs in the healthcare system at large. So we've covered a lot of information this morning. We've talked about the imperative of better using our health data resources to improve population health. We've talked about the challenges associated with doing that, increasing transparencies, building that data infrastructure, increasing trust across the numerous stakeholders who are involved. We've talked about the points of light, the healthcare systems making very significant investment in this space, and the healthcare researchers and providers who are making progress using data and AI to better inform, improve care for certain disease processes. And finally, we've looked at COVID as a good example of the potential of what we can do in using data to better inform our response to a public health crisis. So thinking about our path forward, how are we going to use health data to do what really matters? This is more than a research question. If we think of the healthcare quadruple aim, the tools of population health, enhancing patient experience, improving population health, reducing cost, and improving the work of those who deliver care. To achieve all four of those goals simultaneously is a significant challenge. We've been working on this for decades in the healthcare system. But perhaps the tools of data analytics and healthcare big data will finally help us achieve some of these goals, will finally help us achieve the goals of population health, better health outcomes, improved health equity, and improved health status for all of our populations. Thinking about this conference here today, consider what might your connection be? What partnerships do you have? What collaborations can you build in this path forward as we work together to use health data to do what really matters in the healthcare system, to improve health for all of us?
Welcome back, everyone. What a wonderful talk. Thank you, Dr. Sherrill. And I see we are going to take 5 minutes for questions. And I see we have a couple that have come in. So let's start with the first one from Prasad Babar. Does or should big data include data of human, animal, and agriculture interface to impact public health with a One Health perspective?
That is a great question. The One Health perspective is relative to the health of people, is closely connected to the health of animals and the health of environments. And I'm so glad you asked about this, because actually in that list of categories of data, I should have included that. You're making an excellent point that as we think about these disparate sources of data, that is another one. Health of animals and health of environments connects to these data points. And since Clemson's a land-grant university, you're speaking to my heart when you talk about the One Health approach. We've had a lot of discussions in how to integrate our College of Animal and Veterinary Science and what they're doing in animal disease with how it translates to human disease and how it impacts health outcomes for humans. So great point that you've made there. And absolutely, there's a significant connection between One Health and that approach and this challenge of data and healthcare, health outcomes.
All right, thank you for that. And we have another question from Audrey. She said, how does retaining patient data offer hospitals a competitive advantage?
Absolutely. Thanks for that question, Audrey. Because I did talk about the fact that the owners of much of this health data, large healthcare systems, may be reticent to share the information because it is their competitive advantage. Think about it like this. When a healthcare system is negotiating with third-party payers, if a third-party payer, like a Blue Cross Blue Shield, for example, has access to all the health status of all the patients in their market, what is the health system's negotiation strength if that information is publicly available? So literally, when we talk about patient data, market data is being a competitive advantage for a healthcare organization, that's exactly why that organization might be reticent to share the information publicly, because that provides them negotiating strength with third-party payers in payment negotiation.
Good point. I've never thought about that. But yeah, great answer. We have another one from Shane. Do these big data centers share data with the public and with researchers? Which I think is a little bit of a continuation. So how could these big data centers, how could we as average researchers collaborate with those centers?
That's a great question. I'm not sure I have a very well-informed answer. Again, as we're thinking about the Cleveland Clinic, the Mayo Clinic, the entities like Kaiser who've done a lot of investment in data integration, I think probably they might be, right at this point, a bit of a closed loop where they share their data with their own researchers. I mentioned the Brown University partnership with the Rhode Island healthcare system. Probably that data and information is shared within that closed system with the Brown researchers, but I'm not necessarily sure that it's readily available to all researchers. NIH, as you guys know, has focused more on data sharing as a priority and a regulation when they do NIH funding. But even in that case, we don't have easy and simple ways to access information and data across studies.
Thank you, Windsor. We have time for one more question. And then just to let you know, there are additional questions that unfortunately we didn't have time to get to. So Windsor will continue to respond to those in the chat box after this is over. So our last one is from Stephen Lloyd, and I think it's a great question of kind of where we're going for the future. And he said, doctors are too often reduced to being clerks or typists. And I know you guys have done some great work on trying to create empathy and reminding, your trainees that you do have to have that interaction with people. So his question is, have AI chatbots capture the data to be able to allow for more interaction between physicians? And I guess kind of adapting off of that, where do you see this going for the future?
That's a great observation. There's been a lot spoken about and written about, and the challenge of the fact that our desire to collect a lot of data, or the mandates from payers to collect a lot of data, The demands of the EHR to collect much information has really caused a significant burden on providers. A lot of observations about the fact that it's made healthcare much less personal and changed the whole field of providing healthcare. I think maybe we're at the tip of the iceberg in making progress in using like bots and AI to reduce that burden. Hopefully that'll be another one of the benefits of better integrating these AI and data tools in our provision of healthcare. I think you're making a really great point. This has become, at this point, is more burdensome as far as individual provider-patient interactions than it is helpful. And how are we going to embrace these tools of AI and data to improve that interaction? If you think about it, that's what we're trying to do. We're trying to improve both health outcomes for the population, as well as individual delivery of care between provider and patient. So between those two goals, those two very important goals, we hope that we might see some better use of AI and data science tools to enable those goals.
Great. Thank you so much, Dr. Sherrill. And again, she will continue to answer questions in the chat pod if you have any others that have come up. Just a reminder, we're going to take a 10-minute break. We'll come back at 12:15 for a networking session, and then that'll be a 30-minute speed networking event. Hope you guys can participate. And then at 1:15, we'll start with our breakouts.